Welcome to Essential Brain Imaging Review. This is David Lee Gordon, Professor of Neurology. After viewing Essential Brain Imaging Review, learners will be able to identify key neurologic structures on CT scans of the brain and will be able to distinguish normal and abnormal CT and MRI scans of the brain and identify mass effect, mass lesion, hemorrhage, ischemia, and diffuse cerebral atrophy on these scans. Please note the list of structures that you need to know on the CT scans of the brain, and realize that while you may know most of them, the cerebrospinal fluid structures in particular are often not taught for brain imaging to non-radiologists. The rationale for including them here is that these structures are filled with blood and subarachnoid hemorrhage. If you don't know that they're supposed to be there in the first place as dark structures on a CT scan with cerebrospinal fluid, when they turn white from subarachnoid hemorrhage, you will miss subarachnoid hemorrhage. We shall start with brain imaging anatomy. Please take a moment to identify all the structures listed in red font. Pause this slide and then check your answers on the next slide. We shall start with brain imaging anatomy. On the next several slides, the items in red font are those from the learning objectives. Please pause this slide for a moment to identify all the structures listed in red font. And after you have done so, check your answers on the next slide. The arrows on this slide correctly identify the temporal lobe, pons, fourth ventricle, and cerebellum. Please pause for a moment to identify all the structures listed in red font on the slide. Then check your answers on the next slide. Please spend some time on this slide carefully reviewing the correct locations of the structures listed in red font. Please pause for a moment on this slide to identify all the structures listed in red font, and then check your answers on the next slide. Please spend some time on this slide carefully reviewing the correct locations of the structures listed in red font. Please pause for a moment on this slide to identify all the structures listed in red font, and then check your answers on the next slide. Please spend some time on this slide carefully reviewing the correct locations of the structures listed in red font. Please pause for a moment on this slide to identify all the structures listed in red font, and then check your answers on the next slide. Please spend some time on this slide carefully reviewing the correct locations of the structures listed in red font. Please pause for a moment on this slide to identify all the structures listed in red font, and then check your answers on the next slide. Please spend some time on this slide carefully reviewing the correct locations of the structures listed in red font. Unlike CT scan, MRI scan can view the brain in multiple planes, including the sagittal plane as seen on this slide. This is an MRI T1 sagittal view of the midline of a brain. Please pause for a moment, identify all the structures listed in red font, and then check your answers on the next slide. Please spend some time on this slide carefully reviewing the correct locations of the structures listed in red font. Now let's turn to brain imaging pathology and we'll start with acute blood and mass effect on CT. In neurologic emergencies, the two most important CT findings are acute blood, which is basically white stuff where it shouldn't be, and mass effect, which refers to compression of adjacent structures with possible midline shift and possible increased intracranial pressure. In these 5 images, the red arrows are pointing to acute blood. The yellow arrows are pointing to mass effect manifested by compression of sulci and ventricles, and the blue arrows are referring to mass effect manifested by midline shift, also known as subfalcine herniation. The image on the far left shows blood within the parenchyma called intracerebral hemorrhage. The second image shows blood in the subarachnoid spaces, that is to say subarachnoid hemorrhage. The third one shows the acute blood outside the brain, pushing on the brain. It's called a subdural hematoma, and as you can see from the yellow arrow, this is causing mass effect with compression of the sulci and ventricles on that side. The fourth image shows swelling causing both mass effect with compression of sulci and ventricles and mass effect with midline shift. And the fifth ventricle likewise shows swelling with the yellow arrows showing compression of sulci and ventricles and the blue arrow showing mass effect. The fourth image is from a subacute infarction, and the last one depicts a cerebral abscess with vasogenic edema. Furthering our discussion of brain imaging pathology, let's now review acute, subacute, and chronic blood on a CT. On CT, blood is white or hyperdense acutely, but darkens over time. Subacute blood, referring to days to weeks of blood, is gray or isodense and can be difficult to see on a CT. Chronic blood, referring to blood in the brain for weeks to months, is black or hypodense and is easier to see. These 3 images show the different stages of subdural hematomas. The left image shows a hyperdense white acute left subdural hematoma. The middle image shows an isodense or gray subacute left subdural hematoma. You can see how difficult it is to differentiate the blood from the parenchyma. But notice that the sulci don't go to the edge of the skull. You need to always review the outer parts of the brain when looking at a CT scan. And on the right side, you can see the sulci, the little black wrinkles, abut the bone, whereas on the left side, there are no sulci going to the bone. That's because this rim of blood, the subacute subdural hematoma, has compressed, is in between the skull and the brain, and is compressing the sulci. The far right image shows a patient with actually 2 different subdurals, both acute subdural, the left acute subdural hyperdense white, and the right chronic dark black subdural hematoma. Now let's look at mass lesions on CT, and specifically an abscess or tumor, which appears similarly on CT. On the left, we have a CT scan without contrast, and one without markings and one with markings. And you can see from the markings, number 1 shows the center of this abscess. You can see a vague ring around it. The number 2 is pointing to the vasogenic edema, the dark water that's in the white matter only. It's not involving the cortex. You see the normal gray matter, but the white matter is darker than usual. And then in addition, number 3, there's a mass effect on the compressed ventricle. The ventricle is compressed. And notice also there are no sulci in the entire image. So the whole brain is swollen. The number 4 refers to the mass effect with right to left shift, and the amount of shift is depicted by the red lines. You can actually measure the millimeters or centimeters of shift by doing this on a CT scan in the electronic record system. On the right shows the CT head with contrast. So contrast enhancement refers to leakage of the contrast around the tumor or abscess, in this case abscess. Why does that happen? It happens because tumors and abscesses cause breakdown of the blood-brain barrier. The breakdown of the blood-brain barrier results in water leaking out, and that's what the vasogenic edema is from. Lesions that cause vasogenic edema, water leakage, also enhance with contrast leakage. They go together. Those two concepts go together. Any lesion that causes vasogenic edema will cause enhancement with contrast, and abscesses or tumors commonly do this. Now let's look at acute and subacute infarctions on CT. The upper images show an acute cerebral infarction 4 hours after last known well, and the bottom images show a subacute infarction 4 days after last known well. And you can see the major differences. Let's start with the acute cerebral infarction. In acute cerebral infarctions, there is blurring of the gray-white junction and sulcal effacement. So much of this person's left cerebral hemisphere in the middle cerebral artery territory is the cortex is darker than usual. It's as dark as the white matter. That's blurring of the gray-white junction. And there is effacement of the sulci. In other words, the wrinkles or sulci are pressed on the left. Notice they are normal on the right. When there is this darkening of the cortex on a CT, that implies the tissue is actually dead and an infarction, not penumbra or salvageable. If the area is very large with this darkness, the patient is a poor candidate for thrombectomy because recovery is not likely. The same patient 4 days later shows that the area of infarction is now darker, hypodense, and is swelling. There's mass effect with compression of the sulci as before, but now also ventricles with midline shift. This is due to cytotoxic edema. That's cell death with swelling. And cytotoxic edema peaks 2 to 5 days after onset of the cerebral infarction. Now let's review infarctions on MRI scans, specifically comparing new versus old on MRI. And the way to do this is to compare the diffusion-weighted imaging, or DWI, to a T2 fluid attenuated inversion recovery image called T2 FLAIR. If you compare these two, one can determine the age of infarctions. So these two images show MRI brain images, DWI on the left, T2 FLAIR on the right, of the same patient at the same time. In this patient, the infarction on DWI has to be less than 1 day old since it appears on the DWI but not the FLAIR. DWI shows new infarctions from the first few minutes up to about 28 days, but does not show older infarctions. No infarctions older than 28 days for sure. The MRI T2 FLAIR shows old infarctions at least a day old, but does not show newer infarctions. It starts to show infarctions at a little after a day or so. So this infarction, since it shows up on the DWI, not the T2 FLAIR, must be within the last day. One of the issues that commonly confounds even radiologists is differentiating different types of deep white matter lesions on MRI. This slide shows 3 different T2 FLAIR images from 3 different patients. On the far left, we see chronic ischemic changes showing up as white matter hyperintensities. Notice that the smaller lesions are periventricular, they're near the ventricles, but they're round or ovular in shape with the axis parallel to the ventricular axis. There's also patchy periventricular white matter changes in the forceps major. That refers to the white matter more posteriorly. This is almost due to chronic hypertension. And so that goes with the ischemic changes. The middle image shows multiple sclerosis plaques. Now these deep white matter hyperintense lesions are also periventricular, but their ovular shape is perpendicular to the ventricular axis, and a couple of them even abut the ventricle, which is common in MS and not so common for stroke. especially the ones posteriorly, actually abut the ventricle. The image to the right shows several deep white matter hyperintensities that are more distal. They're not so paraventricular. They're more at the gray-white junction, and they're small, and they're round, and they have blurred borders. These are consistent with migraine. Migraine with aura patients have these migraine-related hyperintensities, sometimes called unidentified bright objects, or UBOs. So if one looks carefully at the features of deep white matter lesions, one can often distinguish the etiology. Most trainees get exposed to MRI scans of the brain on the neurology inpatient services. And many of these patients are older and therefore have some element of diffuse cerebral atrophy. Though I want to make it clear, in my opinion, there's no such thing as age-related cerebral atrophy. It just varies with each patient. But I wanted to compare these two slides, these two patients, a normal MRI in a 41-year-old with normal cognition. That's images A, B, and C in the upper half of the slide. And then images A, B, and C show MRI scan from a patient who is 71 years old with dementia, showing diffuse cerebral atrophy. I want you to be very carefully look at this and notice that the one with the atrophy down below has increased space around the brainstem, has large sylvian fissures, has enlarged lateral ventricles, including the temporal horns. Look carefully at the temporal horns, and the sulci are larger. The images above in the top half of the slide are normal. That's what a normal brain looks like, and you can be normal at any age, but they're normal. The one down below, the three below, depict atrophy. They're not normal. So I want you to know what a normal scan looks like in regards to the sulci and ventricles, and an abnormal slide. Please review the learning objectives for Essential Brain Imaging Review and determine whether you can in fact identify these key neurologic structures on CT scans of the brain, and if you can in fact distinguish normal and abnormal CT and MRI scans of the brain, and identify mass effect, mass lesion, hemorrhage, ischemia, and diffuse cerebral atrophy. Thank you for viewing and listening to this presentation. This is a DLG Insight production, innovative neuroscience ideas and thoughts on education.